afternoon, everybody, and welcome to today's Public Health Ontario Rounds presentation on PHO Rounds SARS-CoV-2 Genomics for Public Health Surveillance. My name is Michelle Murdy, and I'm the Medical Director of Public Health Ontario, and it's my pleasure today to be moderating today's session. Before we begin the presentation for today, I'll start with a few housekeeping items. First of all, the chat pod has been disabled to limit any distractions during the presentation. Please use the Q&A pod if you have questions during the presentation. A discussion and question period will follow the presentation. You may enter questions throughout the presentation and they will be answered at the end. At any point during the session, if you experience technical issues, please email capacitybuilding@oahpp.ca. I'd like to say at the start that as moderator of the session, I do not have any potential conflicts of interest to declare. It's also now my pleasure to introduce the speakers for today's presentation. We have Alex Bershon-Austin and Dr. Samir Patel. Alex is the Genomics Program Lead at Public Health Ontario, and he completed his MSc at the University of Toronto in the Laboratory Medicine and Pathobiology program, focusing on whole genome sequencing of Bordetella pertussis. Prior to returning to PHO in 2021, Alex held various roles within the Public Health Agency of Canada and Public Health Ontario related to laboratory-based surveillance of infectious diseases. Dr. Samir Patel is Deputy Chief of Microbiology and Laboratory Science at Public Health Ontario. Dr. Patel has been with PHO since 2009 and has been the clinical lead at many programs at the laboratory, including antimicrobial resistance, tick-borne pathogens, including Lyme disease, and has been the lead of PHO laboratory scientific programs since 2017. During the pandemic, Dr. Patel has been involved in many aspects of COVID, most notably as scientific lead for PHO's COVID-19 Genomics program. He's also an associate professor in the Department of Laboratory Medicine and Pathobiology at the University of Toronto. Now my pleasure to turn it over to our speakers for today.
Thank you, Dr. Murdy, for the introduction. I'll go straight into the presentation. Neither of us have any conflict to report. We have not received any financial support or any in-kind support from the commercial sponsors. The outline of the talk today is we'll talk about the role of whole genome sequencing in public health. We'll talk about role of whole genome sequencing related to SARS-CoV or COVID-19. What are some of the activities and initiatives we have been doing related to SARS-CoV-2 genomics in Ontario, and also talk about some of the genomics outbreaks and genomics and outbreaks related activities. The objective of this talk is that hopefully participants will learn about the application of whole genome sequencing for supporting the pandemic response. We will be describing some of the key steps in process for whole genome sequencing of SARS-CoV-2 Ontario. We'll also talk about some of the, discuss the role of whole genome sequencing for supporting the pandemic response, describe the relationship between mutations and the lineages, whether it's a VOC or variant of interest. And we would like to talk about some of the surveillance activities related to whole genome sequencing that PHO and other labs have been involved in throughout the pandemic. Just some of the acronyms that we will be using. Sometimes we may use just the acronym or spell it out. So WGS refers to the whole genome sequencing. VOC, a variant of concern. VOI, meaning variant of interest. PCR, polymerase chain reactions. And we will also be using some of the technical words like CT values, which relates to the cycle threshold with respect to the PCR testing. So we'll go straight into what is the role of whole genome sequencing in public health? Well, just some of the context for the last 2 decades of whole genome sequencing with respect to the microbiology. When we compare to the first SARS-CoV, which occurred in 2002-2003, there were only 3 genomes that were publicly available in the first month of the outbreak. Subsequently, within 3 months, there were 31 genomes available. Now, recognizing that there is a significant difference between the SARS-CoV and SARS-CoV-2 with respect to the extent of the outbreak and the duration of the pandemic that we've been involved in. But just looking at the SARS-CoV-2, we had 6 genomes within 3 weeks, and within 6 weeks, there were 60,000 SARS-CoV-2 samples underwent whole genome sequencing, and these sequences were available publicly for scientists and other researchers across the globe to study, understand, and utilize the pathogens and the evolution of pathogen. As of last week, August 19th, or 2 weeks ago, there are close to almost 3 million genomes are publicly available, and this number is continuously to increase day by day. So what happened between 2002 and 2019? Well, there is a significant improvement in technology, whether it's an Illumina technology or nanopore, Oxford nanopore technology, ion turn. There is multiple different technology that have come into the market for whole genome sequencing. The cost has significantly reduced compared to what happened 20 years ago, and we're able to sequence multiple hundreds of samples in one single run. So the throughput has increased dramatically as well. Now, what are some of the applications of whole genome sequencing with respect to microbiology? So certainly it can be useful if you have a genetic sequence of a pathogen. You can use that to develop a diagnostic assay, such as a real-time PCR assay for detection of a pathogen. Certainly, it's been very useful in understanding the virulence of the pathogen. If it's a bacteria, you can detect and characterize antibiotic-resistant genes. If it's a virus, such as influenza, you can also identify and characterize some of the antiviral genes that have been used for influenza as well. Certainly, because of the pandemic, we're able to monitor the changes in pathogen, and this will then relate to the VOCs and VOIs, the detection of those lineages. It's certainly been used for the vaccine development, and once the vaccine is developed and deployed, we can certainly use for the vaccine breakthrough. And we've seen that, and we've studied in some of the measles outbreaks and other vaccine preventable diseases as well. Assessing in the reinfection, and of course, the biggest one from the public health perspective is to characterize and identify and support outbreak investigation. So these are just some of the examples that we've all gone through with the emerging diseases in the last 10, 12 years, starting for the pandemic H1N1, and certainly the genomics as the years went through has played a critical role in the public health response and understanding diseases as well. So back in 2009 with the pandemic H1N1, certainly whole genome sequencing was used to look at the reproduction numbers based on the gene sequencing, and using the retrospective samples, it was identified that actually the PH1N1 was circulating 2 months prior to identification of the first sample. With respect to MERS outbreak in Middle East, whole genome sequencing played a pivotal role in identifying camels as a reservoir. And through that application, it was shown that the transmission, there were multiple transmission occurred from camels to humans, and humans was a dead-end host. Certainly with the Ebola outbreak that occurred in Africa, whole genome sequencing was used in real-time analysis to understand the origin of transmission, the evolution of transmission as it moved and spread across multiple countries. And it was really determined the spread was mainly due to human transmission, unlike MERS, which was occurring from animals to human transmission as well. And certainly in 2016, Zika virus, we were able to do whole genome sequencing in real time to understand where it came from and how it spread in South America. So what about whole genome sequencing with respect to SARS-CoV-2 and COVID-19? So just a little bit of background on the makeup of the virus. We know the SARS-CoV-2 is an RNA genome. It's made up of about 30,000 base pairs of nucleic acid. The genome codes for 6 proteins that perform the functions of replication, infection, and viral structure, maintenance of the virus. And of those 6 proteins, the spike proteins, and we'll go through more during a VOC and VOI is responsible and important for binding to specific receptors on human cells. As the virus replicates, just like any other viruses, errors are introduced and mutations can arise that leads to a genome sequence, changes to the genome sequence and function of proteins as well. One thing to remember with respect to SARS-CoV-2, it does have a proofreading mechanism, and therefore the errors that are introduced and subsequently propagated is much less than other viruses such as influenzas and all. And that was one of the reasons why we saw less diversity in the beginning of the pandemic and throughout, until January of 2021, December of 2020. So what are some of the applications? So I had talked about that it was, whole genome sequencing can be used for the development of diagnostics, and this was no different, and probably one of the fastest test that was developed using the whole genome sequencing. And many of the labs did not have the positive controls, but they did have access to the sequences. So in December 31st, 2019, WHO China office was informed of cases of pneumonia with unknown etiology. By January 10th, the first genome was publicly posted. Subsequently, 2 days later, additional 4 genomes were published as well. This really facilitated in the development of diagnostic assay. In absence of positive material, researchers in Germany were able to develop a diagnostic assays that we still use in terms of the RDRP as a target, E gene, and the N gene as well. What about the other applications? So again, I'm just going to go through some of the examples of where whole genome sequencing can be used and has been used. So in this case, WGS was used to determine whether or not the patient was reinfected or was continuously shedding from the previous infection. So this is a 33-year-old male who was immunocompetent, otherwise a healthy male. First diagnosis was made in March 26th of 2020. And then subsequently, the second diagnosis was made on August 15 when he returned from Spain. The patient on the second diagnosis was completely asymptomatic, and the diagnosis was picked up at the airport as part of the screening as well. And using the whole genome sequencing of both specimens that were available, they were able to determine that really the second episode was due to reinfection rather than the previous ongoing shedding of the infection. And they were able to identify changes in the genetic sequence, difference in the genetic sequencing between the first infection and the second infection. And this is just a phylogenetic tree showing that in the bottom, where the whole genome sequencing clustered in the bottom half of it, where in the second infection, the whole genome sequencing was significantly different than the first infection, confirming that this was indeed a reinfection in this patient. Again, there were other examples where in this particular cases, whole genome sequencing was able to demonstrate and confirm transmission between the minks and the farmers who were in the close contacts with the minks in Netherlands. This was in this paper, they investigated outbreaks on 16 different farms that occurred in Netherlands between April and May of 2020. And both the whole genome sequencing and epidemiological information concluded that there was indeed a transmission occurring from minks to humans and humans to minks. And these are some of the examples on the right-hand side. Each color represents different outbreaks, and you can see a very close clustering of sequences that were recovered from humans and compared with minks animal as well. There was very little diversity between the samples that were collected from humans and the minks, and the diversity was, in terms of the closeness, some of the samples had 0 nucleotide differences, meaning absolutely identical sequences between the animals and the humans as well. When they compared it to the community strains that were circulating, they were able to show that indeed the humans, indeed the significance was different. And again, this was a transmission occurring within individual farms. This was another example of a multi-ward outbreak in Ireland early in the pandemic. They were able to differentiate the clustering occurring in the different wards. And the conclusion was that they were being introduced in a different ward, and there was a significant nosocomial transmission occurring between the patient and the healthcare workers in the different wards as well. It's with this information, as well as the increased infection control and prevention measures, interventions, they were able to control the outbreaks and stop the transmission occurring within individual wards and within the hospitals as well. Also, UK has one of the best genomics program. They have been doing genomics on microbiology pathogens for the last 10, 15 years. And they leverage that infrastructure to perform a whole genome sequencing program at the national level. And they were really able to establish and monitor the changes in the lineages from onset of the pandemic and throughout the pandemic. On the right-hand side, you can see that early in the pandemic, most of the lineages or the cases were related to cases coming in from China. And as the pandemic went on, starting February, most of the introduction, if not all of the introduction into the UK was as a result of cases coming from, or patients, travelers coming from European countries such as Spain, France, Italy, and elsewhere as well. The second figure, the middle figure, shows that as the pandemic wore on, they were able to see that most of the lineages that were introduced disappeared, and there were some of the lineages persisted and resulted in the transmission and the expansion of those particular lineages into the community as well. Again, so let's talk about some of the mutations and lineages. I've mentioned lineages many times. What constitutes the lineages? Well, as I mentioned before, the mutations in the viral genome occurs regularly, and it can accumulate over time. In this case, SARS-CoV-2, as I mentioned before, that it does have a proofreading mechanism that is able to slow the accumulation of mutation, but nonetheless, it does mutate and accumulates over times as well. As mutation accumulate, the genome becomes more different than the original lineages. And some of the new lineages may have biological implications, including increased virulence, increased transmissibility. It can also, may also evade natural vaccine-induced antibodies, may resist therapeutics such as monoclonal antibodies that have been used to treat SARS-CoV-2 infection. And also, it can have a diagnostic impact as well. As I mentioned before, if there is a changes in the nucleotide and genetic material, and if you're testing using PCR testing, it may adversely affect diagnostic performance characteristics as well. So the mutations and lineages gained a significant interest in early December of 2020, when the UK reported a specific lineage that made up of 50% of cases in certain parts of UK. It was initially designated as a variant under investigation because they knew that this was a different lineage, had multiple different mutations that could have a biological impact on it as well. So initially, from the laboratory perspective, they termed it as a variant of investigation. One of the notable mutation was the mutation at N501, is in the S gene, as I mentioned before. And it was implicated that it has an ability, this mutation has ability to increase binding affinity to human epithelial cells. Subsequently, additional epidemiological and clinical investigation led to UK redesignating this strain as a variant of concern. And this was the first variant of concern, known as B117, or now we're known as alpha variant as well. On the right-hand side, you can see that it has multiple different mutations, and some of the mutations, such as N501, has been shown to have a biological implication, such as increasing binding, which leads to potentially increase in transmissibility. On the right-hand side and in the left-hand side, we identified the first 2 cases in Canada, in Ontario, in December 26 of 2020, a couple of weeks after knowing the detection of B117 in UK. And we also, unfortunately, had one large outbreak involving long-term care facilities early in January 2021, involving B117 that had led to significant mortality in the residents of that particular long-term care facility. In Canada, and particularly in Ontario, by March and April of 2021, most of the cases were related or were associated with B117. And this happened similarly in UK as well. The purple area shows the almost 80 to 90% of the cases were from as a result of the B117 lineages, and other lineages that were circulating prior to January had almost disappeared. So let's talk about what constitutes a variant of concern or variant under investigation, or what constitutes a variant of concern. And these are the definitions that have been put forward by the SARS-CoV-2, Canadian SARS-CoV-2 variant working group. Variant of interest is a lineage that has mutations that are associated with changes in epidemiology and virulence, or have a negative impact on diagnostics or the therapeutics, including the vaccine escape as well. In addition, it must have that that ability to cause community transmission or clusters in multiple countries. Or variant of concern, on the other hand, needs much more information, such as epidemiological information, clinical information. So it must fulfill either increased transmissibility or detrimental to COVID-19 epidemiology, or increased virulence, whether it's a clinical disease presentations or the outcome, decreased in effectiveness of diagnostic or vaccine therapeutics. And some of the notable mutations that we've talked about, and I'm sure a lot of you have known about these, is N501, as I mentioned before. It's found in the multiple different VOCs, including B117 alpha, 351, as well as the P1 as well. Another notable mutation is a mutation in the E484K position in the S gene as well, and has been shown to appear in multiple different lineages. This particular mutation may lead to reduced antibody neutralization, whether it's a de novo antibody production or vaccine-induced antibody production as well. And then again, there is another mutation, K417T or N, has been found in beta as well as gamma VOCs as well. Yeah, no, great. Majority of them are saying that it's found in beta and gamma. Yes, it is found in beta and gamma. There have been some cases of 484K mutation is also found in alpha as well. So yes, there have been some cases, although we haven't seen a lot of B117s lately that contains the E484 mutation. In terms of the lineage assignment, again, we've talked about alpha, beta, gamma, or B117, B351s. There are multiple ways of classifying different lineages, depending on the databases and that you use. Notably, there are 3 different ways of identifying lineages. In this case, we're using Pango lineage, which is the most commonly used nomenclature to identify and follow the lineages as well. Some of the variants of concerns and variant of interest, again, Pango lineage, it's most commonly known as B117, 351s, and the P1. There are also different ways if you're using a GSED to identify the strains or the clade, as well as the next strain as well. To make it easier, WHO has begun, and several weeks ago, or a month and a half, 2 months ago, using a Greek letter to identify different lineages. So B117 has been identified as alpha, P1, gamma, and most commonly a seen strain in Canada, in North America, Delta, is B1617.2. And these are some of the variants of interest that have also been identified using the Greek letters, eta, iota, and kappa, lambda, that we're continuing to monitor to determine whether or not this would constitute a reclassification into variant of interest. So with that, I'll pass it on to my colleague.
Thanks, Samir. So hi, everyone. I'm Alex Austin, and I'll be talking about the next portion of the presentation where we focus really on SARS-CoV-2 genomics in Ontario. So just to give an overview of how we're doing the testing, there are a lot of people involved in this. As you can imagine, it's a pretty involved laboratory method. So in early March 2021, the Ontario Covid-19 Genomics Network was established to increase the genomics testing capacity in the province. Now, what this means is there are 5 laboratories that are part of the network, including Public Health Ontario Laboratory, as well as 4 partner laboratories at the Hospital for Sick Children, Shared Hospital Labs, Kingston Health Sciences Center, and Hamilton Regional Laboratory Medicine Program. So routing all of these specimens between all of these labs is quite an involved process, and we are graciously supported by Ontario Health in terms of coordinating all of that specimen routing. Now, a little bit more on the specimen logistics part of things. The WGS program is really built on a tiered system where there are sort of 3 levels of testing, where there's the first or initial COVID diagnostic test that is performed by over 40 laboratories in the province. I believe it's close to 70 laboratories now that are doing the initial diagnostic testing, and this includes hospital, community labs, as well as public health laboratories. So all specimens that are positive for SARS-CoV-2 with a CT value of less than or equal to 35, and that again is a requirement for the proper interpretation of the test. Those are sent to one of 11 VOC PCR testing laboratories for N501Y and E484K testing, as Samir alluded to those specific mutations and their association with certain lineages in the first half of the presentation. So there are 11 labs who perform that second level of testing. And then from there, select specimens with the CT value of less than or equal to 30 on that VOC PCR analysis are sent to one of the 5 COVID genomics laboratories for whole genome sequencing. So what specimens get WGS? The main overarching criteria here is that in order to ensure the sequencing analysis is working correctly or is yielding high quality results, we have a CT requirement that all specimens need to be less than or equal to 30 to ensure there is enough genetic material for sequencing. Aside from that, there are 2 buckets that our whole genome sequencing approach falls into. The first being representative sampling. So this started back in May of 2021, where the COVID Genomics Network started using a representative sampling framework in order to identify specimens for whole genome sequencing. And this replaced the previous approach, which many of you might be aware, where sequencing was based on the VOC PCR results. So that E484K and N501Y result, those results were what was dictating which specimens were going to get whole genome sequencing. Now that created some issues in terms of biasing what we were seeing as far as whole genome sequencing at that point. So that representative sampling allowed for the relative proportions of each of those lineages that are circulating in Ontario to be monitored for changes. So previously, when we were testing only those that were 501Y positive or 484 positive, we couldn't really tell the differential proportions of each lineage circulating in the province, as we were only sequencing a large chunk of select lineages. So the representative sampling allows for this more broader representative sample to occur. And what this also does is it allows us to scale the number of specimens that we're sequencing to the network sequencing capacity, which is 3,500 specimens per week. Now, if we're doing direct sequencing only based on the VOC mutation result, it is relatively inflexible to to the sequencing capacity, and we're subject to issues with capacity as waves increase and decrease. So what this means practically is that a proportion of all CT eligible, so again, less than or equal to 30, a proportion of those specimens are tested by VOC PCR are selected randomly to go forward for whole genome sequencing. Now, this proportion varies between 10 and 100% based on current and projected case counts, again, relative to our capacity, and also considers the proportion of all positives with eligible CT values. So right now, what we're seeing is roughly 60% of all positives have an eligible CT value of less than or equal to 30. So out of all of the SARS-CoV-2 positives that we see at the initial diagnostic lab, roughly 60% of those have a CT value of less than or equal to 30 at this time. So we do provide notice of change. So as you can imagine, all of the specimen logistics of sending specimens to different labs. So we provide the VOC PCR labs 1 week advance notice. And we also announced those changes. I'm sure many of you on this call heard from me at last week's Public Health Coordination teleconference, where we announced an upcoming change. And I'll be going over the changes that have occurred historically in a few slides. So the second bucket of specimens that get whole genome sequencing is what we call targeted sampling. So these are specimens that are sent directly, well, not directly, but are sent for whole genome sequencing when the requisition indicates international travel or vaccine breakthrough. So it's important to note that these specimens are included in the representative sampling. So the sampling occurs first, where all specimens are available to be part of that representative sample. But then in addition to that, any specimens with international travel or vaccine breakthrough that weren't selected are passed on forward for whole genome sequencing. Sort of separate from the Ontario Covid Genomics Network, there's also whole genome sequencing being performed on specimens collected as part of land border testing programs. So the Public Health Agency of Canada is running a land border testing program, and that whole genome sequencing is performed by the National Microbiology Laboratory, along with day 8 airport testing. So Public Health Ontario is actually doing the day 1 airport testing, but day 8, which are patient-collected specimens, are actually done by the NML. So that's a sort of a side pool of specimens that are also undergoing whole genome sequencing. And all this, in addition, that we can also do some sequencing on request to help support outbreak and suspected reinfections investigations through phylogenetic analysis, although some restrictions do apply, which we'll get into a little bit later in the presentation. So as far as the representative sampling changes go, there have been 4 changes to date. So the initial implementation during the rise of the third wave happened at the beginning of May. We made a slight adjustment as the cases started to fall in order to increase our capture of specimens going for whole genome sequencing and leverage our capacity as case counts went down. Finally, in mid-June, we switched to 100% coverage, where we were sequencing all positives that came through, as we did have the capacity to do so. And now, sadly, last Friday, as announced on the aforementioned public health coordination call, we have switched back from 100% to 50% in order to accommodate the rise of cases throughout the 4th wave. Now, as far as requesting whole genome sequencing goes, the sort of caveat emptor to all of this is that whole genome sequencing results are mainly, or are best used for population level surveillance, and really have limited use for individual clinical and public health management, with a few exceptions that Samir detailed earlier. So for reinfections investigations, for IPAC cohorting decisions, as well as for outbreak management. But all in all, the best utility of this is from the UK model, where it's used for really understanding the ebb and flow of specific lineages at the population level. So when proportional sampling is at 100%, there's obviously no need to request sequencing on specimens as everything is getting sequenced. And the important part as well is that this representative and targeted sampling is really only performed by the VOC PCR testing laboratories, and is not associated with the test request process. So there are things that we are looking for on the requisitions, mainly as it involves travel and vaccine escape. But for the most part, it is the VOC PCR testing laboratories who are selecting the specimens that are coming on to us for whole genome sequencing. So there are, for requests that are coming through, we do require, if there are specimens that are being requested above and beyond those sampling processes for assisting the health units in their case investigations, we do require the requester to arrange for the specimen to be sent from the VOC testing lab to the whole genome sequencing lab. Now, this is where the specimen logistics are quite complicated in that, different specimens will have reached different laboratories throughout the network by virtue of their sample collection. So Public Health Ontario only has real visibility into their own specimens. So coordinating that through the network, we realize that this is quite labor intensive, but is mainly being requested by the requester to arrange the identification and location of those specimens and to have them submitted to a whole genome sequencing lab via the existing channels. So specimens that are sent must be accompanied by the requisition that's shown here on the left, and that's available on our variant of concern surveillance test information sheet. And then any special requests that we'll get into in the next few slides, they may require additional information and approval as well based on capacity and the ability of whole genome sequencing to answer the question being asked. And we ask that these go through our PHO laboratory incident and outbreak response team prior to requesting to make sure that we are able to get you what you need. Now, speaking of outbreaks, this brings up a good time to have our second poll question raised. So Lydia, if you please bring up that one. So the question that we're asking is, whole genome sequencing can confirm transmission between cases of SARS-CoV-2. So we'll give it a few minutes for those to respond. And pretty good 50-50 split. And I think that represents sort of the ambiguity or the it depends nature of this question. So I think it's, as far as being right or wrong, it's less important, but more so to appreciate the context of under these that relates to this question. Now, as Samir indicated in the first half of the presentation, as per the mink farm where transmission was determined between minks and humans at specific farms. Now, that transmission sort of identification really is contextually dependent, where having minks and humans in the same spot and both testing positive for the virus sort of provides additional weight to the implied transmission. The thing with SARS-CoV-2 is that it changes very slowly, and it isn't uncommon for us when looking within outbreaks to find identical sequences both within the outbreak that may be suggestive of transmission, but there may also be identical matches found hundreds of kilometers away that are implausibly related with a given outbreak, just because of the slow rate of change of the SARS-CoV-2 virus. So in terms of outbreak investigations, whole genome sequencing is better at ruling out transmission. So if we see a certain amount of difference between specimens, we can say that this is unlikely to be the result of direct transmission. However, two sequences that are exactly the same aren't necessarily indicative of transmission without any additional contextual information. So that's why, I hope that's why that reflects the 50-50 split on the poll. But again, context is extremely important, and the epidemiological data that's collected as the part of through investigations is key for making those interpretations for whole genome sequencing. So that said, in terms of outbreaks where whole genome sequencing has been outlined as its ability to support it, PHO is in the process of formalizing a centralized process for intake. Now, the specimen logistics piece that I alluded to earlier makes this outbreak response portion of whole genome sequencing extremely challenging from a timeliness perspective. Now, the first few specimens from an outbreak may not have been identified as such and may have been tested at other laboratories. If we're talking about a long outbreak with many specimens, these can also be spread across multiple laboratories. So collecting all of these specimens together with all of the accompanying information is part of the process that we're looking to formalize. So getting that intake data as well as those reporting templates. Aside from that, some outbreak specimens will be picked up as part of the representative surveillance, and those are sequenced without requiring any requests. If there are additional specimens that you require to be sequenced, these can be requested if the lineage information will help support that response. We can also do in-depth phylogenetic analysis if we're looking to test specific hypotheses about transmission. But again, this involves a lot of specimen logistics, collecting everything together, as well as there's a lot of work that goes into the interpretation of this as well. So talking about individual patient reports. So this is our main vehicle for getting whole genome sequencing results back to the health units, the ordering providers, and through OLIS. You'll know that non-VOC lineages are reported out as variant of concern not detected. So we're only reporting VOC lineages by name. Also a note that there are recently been VOC sublineages that have been identified. Many of you may have heard of AY3. These are actually being reported out under the parent lineages. So Ontario is actually one of the only jurisdictions in Canada that is reporting back VOC lineages on individual reports. And this is challenging because non-VOC lineages, as Samir introduced in the Pango discussion earlier, that these classifications are dynamic and subject to reclassification, which makes it difficult for one-time patient reports. More so down the road, as far as CCM logic goes for populating the result values for whole genome sequencing in CCM, these take time to develop, and the lineage changes are far too quick to be able to keep up with that. So that sort of guided our discussion or our decision around only reporting on variants of concern. So our main vehicle for reporting on our whole genome sequencing is our aggregate report. So this is a weekly report that goes out on Fridays, includes all VOC, VOI lineages. So VOI are those that you won't see necessarily on the individual reports coming through OLIS or on the patient reports. And this is done for Ontario overall, as well as select breakdowns by public health unit. We also link these results to CCM to assign the correct PHU. And then also look at some disease severity and outbreak status. So just a sample of what's in that aggregate report. This first table shows the proportion that have been sequenced on any given week. You'll notice that even though we were sequencing 100%, we are only at about 60% of all cases sequenced overall. And this again reflects the proportion of cases that are CT eligible. So that is reflected in that first table, but gives you a sense of how much we are doing. This first figure also shows is the main deliverable from the representative surveillance, where you can see the relative proportions of circulating lineages. That big yellow blob in the middle, you'll recognize as Delta, as has squeezed out most of the other lineages at the moment. So just going over a few other components of this report. Here we're talking about outbreak versus non-outbreak associated. It's a breakdown by lineage here. So this is again enabled by our CCM linkage and gives an idea of different lineages' propensity to be associated with outbreaks as opposed to non-outbreak associated cases. And this is again all VOCs as well as VOIs. Another tool is NextStrain. So this one is a random sample, of 5,000 specimens that are sequenced at Public Health Ontario. So here you can go looking for anything that is not a VOC or VOI. So all lineages are contained in the NextStrain tool as part of that 5,000 specimen sample. So if you're ever wondering, have we ever seen a R.1.495? You can go check at NextStrain, and that's the easiest spot to see that, just being cognizant that it is a 5,000 specimen sample and not all cases sequenced. So just to wrap things up in terms of future directions, PHO, we're building a centralized sequence repository that'll help facilitate getting all of the sequence data into one spot and then have it available for linkage to CCM and COVAX data, so we can do all of this surveillance in sort of one bucket. Right now we're using interim processes just because of the logistics of moving the data around to enable the provincial surveillance that's happening in the aggregate report. So we're also looking to include additional travel information from border testing programs. We're in the process of acquiring that data to include in the report as well. We're also very close to adding vaccination status breakdown by VOC, VOI to our weekly report. And we're also in the process of investigating additional sequencing technologies to give us some more flexible workflows. As you can imagine, whole genome sequencing is a very laborious, time-consuming process, and any additional tools that we can use to give us more flexibility will be useful there. Also, just to wrap up, in terms of acknowledgements, as I alluded to before, it's a very complicated and involved process, and there are many, many, many people that are involved in helping us get to where we are. Really, this was a nascent program that was sort of built in the pandemic, like I think it's flying the plane while building it, as was the term that was thrown around a whole bunch. And a lot of work was done by a small and mighty team prior to my arrival at Public Health Ontario at the end of February. So just wanted to shout out all of our colleagues throughout the lab testing process, as well as the COVID network, who helped make this stuff happen. Provide our contact information at the end. If you have any questions that aren't addressed in the Q&A, please feel free to follow up with us, and I will end there.
Wonderful. Thank you so much, Alex and Samir, for that really informative presentation. I know Samir has been busy typing away some good questions that have come through the Q&A pod already, but I think we do have a few others that I think would be beneficial to answer live already. So as a reminder to our participants today, if you haven't had a chance to type a question into the pod, please do so now. And we'll go to some that have come forward. I'm going to give this first one to Samir, and Alex, if you want to jump in as well. The question's from Lena. Is there any plans to move away from the PCR testing, the VOC PCR testing that we're doing, the 501 and 484?
Yeah, thanks, Michelle. That's a great question, Lena. We're continuing to monitor the utility and usefulness of 501 and 484 PCR testing that we're currently using. Right now, it's being used to identify rapidly whether or not a lineage could be a Delta variant or not. So as you know, the Delta variant is negative for both 484 and 501 mutation. So absence of that, and we know that the proportion of all negatives corresponding to Delta variant is very high. The PCR does provide a rapid turnaround time, which is not the case with the whole genome sequencing. But yeah, so we're continuing to monitor the usefulness and utility of this screen testing, because it does have a pros and cons of using it.
Great, thanks, Samir. There was another question from Lena here. I think that, Alex, you partially answered in your response in terms of variant breakdown by travel. And I think you mentioned that, yes, you're in the process of getting the travel border information to be able to include that in upcoming versions of the weekly whole genome sequencing report. And the other one is on reinfection over time. So my understanding is, like, we're not reporting on the reinfections as of yet, but I think there are plans for a future more in-depth epi product on reinfections that are looking kind of at a more detailed analysis of the one. So there's just right now, currently in our weekly epi summary, a summary of the number of reinfection cases that have been reported in the province.
Yeah, and I can sort of add on that a little bit. We actually haven't had much reinfection testing thus far, and that's largely based on the CT applicability or the CT eligibility requirements. So often, either the first or second infection doesn't have enough genetic material in the specimen to facilitate that comparison, right? So particularly with this type of comparison where it really involves like single mutations across the genome, we do need relatively high quality sequencing coverage in order to make that comparison. So I think we've only seen a handful thus far where both specimens, were actually eligible to be sequenced, and that we were able to get our hands on them and compare them and sequence them. So it has been getting more challenging as the pandemic rolls on and more people are vaccinated or have been infected. This typically has an adverse effect on CT values as far as what's available in the specimen. So yeah, all that to say that we haven't seen that much of it, but if you do have cases where you do suspect reinfection and it is the cases as per the provincial definition for doing that, please reach out to us and we can see if we can get that. And as Michelle said, we are looking at those more in depth in upcoming report products.
Great. Maybe this next question for you again, Alex. So is there a process by which PHOs could get the full sequence data for doing their own phylogenetic analysis of outbreaks?
Yeah, so this is probably mostly constrained by logistics at this point. So sequence data is quite huge. So like the raw sequence data for doing phylogenetics is just too big to sort of move around realistically, and we don't really have data sharing mechanisms to do so at this point. So we are building the provincial sequence repository as a first step, but that's still a little ways away. Also, even in terms of reporting the lineages out, we understand that ideally the public health units would like to have like a full picture of all the lineages circulating in their jurisdiction to enable like that sort of PHU level analysis. But it's because of the speed at which these lineages designations change, all of our IT infrastructure for getting that information to you via the public health disease of public health significance notification process. So, copy from the healthcare practitioner to the health unit, as well as contribution to OLIS. That infrastructure isn't great for, being flexible enough to capture the constantly changing lineage information that we're getting. So like we're sort of stuck in a hard spot where we recognize that this individual level data would be useful for the health units, but it's really a logistical concern in terms of getting it to everyone. That said, we do deposit our specimens or our sequence specimens in public-facing repositories. So VirusSeq is one of them that's being run by the Cancogen network. We are contributing to that as well as GISAID, which is another repository for sequence information, but that one is a little bit more restrictive in terms of who is provided access. But again, it's challenging with public-facing repositories is that these sequences aren't going to be identifiable enough for this type of use for the public health units, just due to privacy constraints as well. So it's mainly a logistical concern, and like there's also quite a bit of expertise in analysis that's required for doing this type of phylogenetic stuff. It's not really just push a button and it spits out a tree. So these are all the considerations that are sort of preventing at this point for us to share direct sequence information with the health units.
Great, thanks, Alex. And I think just to say, part of that new intake process for outbreak investigations, that it's really a collaborative process. Like often the health unit, the lab, others need to be involved to really pair that epi and genetic information to make a good story out of what's happening. So I think we're looking forward to that new process as well. I know we're kind of running out of time. I think there's lots of good questions there, so I'm not sure we're going to get to all of them. But the next one I'm going to turn to Samir. I think you kind of mentioned this briefly in your presentation, but maybe just to reiterate about how FAC and WHO would make a determination as to whether a new variant is a VOI or VOC.
Yeah, so there are a couple of different ways. There are multiple different national, international working groups that scan the literature. They look at for definition of VOI. What I mentioned is that some of the key, what constitutes a VOI strain is that it must have some of the mutations that we know has a negative impact on biological, whether it's increasing binding to the human cell, whether it reduces neutralization, antibody neutralization activity in the laboratory setting, or whether it negatively impact the diagnostic performance testing. So that constitutes that would be a case of a VOI. In terms of VOC, obviously it needs to have this mutation, but it also needs to be coupled with whether or not can we see increase in epidemiology or increase in transmission rate with the new strain. Does that, can we document increase in severity? Can we document increase in vaccine breakthrough? Can we document increase in reinfection and all of that? So once we meet any of those characterization, it gets upgraded to variant of concern. So there are many groups working on it. The ones I showed you with WHO, Public Health Agency of Canada has it, UK has it. So we continuously monitor all of those websites and organizations to see which one is VOIs and VOCs.
Okay. Thanks, Mary. I think there's a couple of related questions in the pod. I mean, one was asking about whether new lineages affect diagnostic testing PCR. So that can be one of the criteria by which a new variant is considered a variant of concern, is if the variant is escaping current diagnostic technology. So that's a good question. And I think part of what we're looking for in terms of new variants, if they are getting missed by current PCR testing. And there's also a question about whether mutations detected relate to vaccine escape due to immune pressure. And I think certainly that's again one of the other criteria for another variant of concern if we do have evidence of vaccine escape. So important ones there. There's a question here for Rohit. We'll take this last one. If there's any co-infections, I'm presuming that means in Ontario or maybe in Canada, where there's been 2 or more strains within, I guess, the same individual. So it's someone infected with 2 types of COVID at the same time.
Yeah, that's a great question. Again, as far as I know and what I have seen, we haven't seen co-infection of the 2 different strains or lineages. Again, it could be the analysis we're doing. We're not doing deep enough. Because of the lack of diversity in the viruses in this particular virus. Theoretically, it's possible, but we haven't seen any reports of dual infection or someone infected with 2 different lineages or strains.
Okay, well, wonderful. So we're just at 1 o'clock now. As we wrap up today's PHO presentation, I'd like to thank Alex and Samir again for presenting this really wonderful update and summary. I'd also like to thank everyone who joined us for today's session. It's great to see such strong virtual participation during challenging time for public health and healthcare professionals. You can expect to receive a brief and anonymous PHO round survey for today's session. So if you could please try to complete that, it does really help us improve our programming. And lastly, to access any past PHO rounds presentations and view confirmed upcoming sessions, please visit the PHO website, head to Education and Events, and click on Presentations. Thank you so much and have a wonderful rest of your day.